Assalamu alaikum. Today, I would like to present an overview of this critical topic like cyanide poisoning and carbon monoxide poisoning for discussion. Okay, now if we look at this cyanide poisoning, we know that cyanide poisoning is a life-threatening condition resulting from exposure to cyanide, which is a potent. What is cyanide? Is a potent mitochondrial toxin. It's a potent mitochondrial toxin. Mitochondrial toxin. Cyanide actually inhibits oxidative phosphorylation. If we look at the mechanism of the cyanide poisoning, it actually inhibits oxidative phosphorylation. Phosphorylation. It actually inhibits oxidative phosphorylation. So, two words we need to remember: it's a potent mitochondrial toxin. It in it inhibits oxidative phosphorylation. Thereby, it's block the ATP production via it blocks the ATP production via aerobic metabolism. Okay, these force cells to switch anaerobic metabolism. So, as it is blocking aerobic metabolism, so it actually switching to form anaerobic metabolism thus leads to increased production of the lactic acid, thus causing increased production of these lactic acid. And profound metabolic acidosis, there is profound metabolic acidosis. We know that cyanide poisoning can cause high anion gap hugma high anion gap metabolic acidosis. So cyanide poisoning hugma increased lactic acid due to anaerobic metabolism. Early acute toxicity, it is characterized by, if we look at the toxicity, there may be multiple features, multiple symptoms. Before jumping into the clinical feature, I would like to tell about some risk factor about cyanide poisoning. If you see in the stem, like house fire, like structural fire, like combustion of the plastics, occupational exposure like mining, occupational exposure like mining, and sodium containing medications, sodium containing medications like sodium nitroprusside, sodium containing medication like sodium nitroprusside. These antihypertensive medication, the sodium nitroprusside, is an antihypertensive medication, is metabolite to nitric oxide and cyanide ion. And prolonged infusion, if we give prolonged for more than 24 hour or higher dose, especially in patient with renal insufficiency, renal disorder, it can lead to cyanide toxicity. So, sodium nitroprusside should be given in a patient without renal insufficiency. If you give a patient with renal insufficiency, or if you give for prolonged period of time more than 24 hours or at a high dose, it can cause. And there are some dietary source consumption like uh, bitter almond, bitter almond, and like some dietary source like cassava, it actually can cause cyanide toxicity. Okay, if we look at the pathophysiology, I have already told you it inhibits oxidative phosphorylation and forces anaerobic metabolism by blocking aerobic. Okay, if we go deep in this mechanism, if we go deep in this mechanism, cyanide actually binds to which ion? Ferric. Cyanide actually binds with ferric in the cytochrome C. ferric in the cytochrome C oxidase, which is a key enzyme in a mitochondrial electron transport chain and thereby inhibited the production of the ATP from oxidative phosphorylation. Okay, so cyanide binds with ferric. So potent mitochondrial toxin, it blocks oxidative phosphorylation, it binds with ferric. Okay, now if we look at the clinical feature, there are some early signs, there are some late signs. If we divide into this, and patients like who inhale cyanide may report noticing a bitter almond odor, a bitter almond odor. Okay, in acute toxicity, it can infect CNS and thus can cause headache, confusion, dizziness, agitation. It can involve the CVS, thus causing hypertension, tachycardia, tachypnea, circulatory collapse, and death. It can cause in skin. It can cause cherry red color. This cannot the tissue cannot effectively use oxygen, so venous blood remains saturated with oxygen and appears a bright red, an uncommon but classic finding. It's a classic finding, cherry red skin. It happens when the tissue cannot effectively use oxygen and venous blood remains saturated with the oxygen and thus causing appear this red. And in the long run, in prolonged toxicity, it can cause seizures, it can cause bradycardia. Initially, it causes tachy, but then it causes bradycardia, it can cause respiratory failure, and it can cause cyanosis, kidney failure, n- and hepatic liver necrosis can happen. Okay, what is its management? Before jumping into the management, if you find a case with cyanide poisoning, what should be your DDs, differential diagnosis? One of the differential is carbon monoxide poisoning. One of the differential is meth methemoglobinemia. Methemoglobinemia. One of the differential is salicylate toxicity, and finally sepsis and septic shock. So one of the differential is carbon monoxide poisoning. This is a very high yield, and carbon monoxide patient present like cyanide toxicity, like headache, seizure, mental status, lactic acidosis, a high carboxy hemoglobin level confirms high carboxy hemoglobin level actually confirms the carbon monoxide poisoning. These two conditions can occur simultaneously, especially in house fire patients. So, in house fire patient, you are unable to know that is it carbon monoxide or is it cyanide, or it can occur simultaneously. So, if we do carboxy hemoglobin level, it can confirm the carbon monoxide poisoning. And next differential, actually methemoglobinemia, it actually alters hemoglobin, but so it cannot bind or deliver oxygen. It actually alter hemoglobin, so it cannot bind or deliver oxygen. The resulting hypoxemia can lead to altered mental status, seizures, respiratory depression. And in methemoglobinemia, there is chocolate brown color rather than the cherry red. If you found the case with chocolate brown color rather than the cherry red, looks like methemoglobinemia. Methemoglobinemia is associated with like the leprosy drug like Dapsone, like nitrate, like topical or local anesthetic. Okay, how to manage a case? Before management, uh, I would like to talk you about the labs. What you will find in the lab. In the lab, there is HAGMA, high anion gap metabolic acidosis, found by ABG, and venous blood gas show narrowing of venous arterial PO2 gradient, narrowing of venous arterial PO2 gradient. Serum lactate would be high due to increased anaerobic metabolism. Finger stress glucose, there may be hypoglycemia. Complete metabolic panel to assess renal and hepatic dysfunction, because renal insufficiency can happen. And carboxyhemoglobin level to look for, is it co-poisoning with carbon monoxide, and salicylate and acetaminophen level to look for salicylate toxicity, one of the differential. So in lab we should do it. And if we do some imaging, chest x-ray to assess some inhalation injury, we can do chest x-ray to look for inhalation injury partially with smoke exposure, and CT scan of the head to evaluate for intracranial hemorrhage. CT scan for intracranial hemorrhage. If we know the treatment in short, like decontamination should be done, supportive care 100%, oxygen, IV fluid, vasopressor. So in cyanide, 100% oxygen, and empiric treatment, hydroxocobalamin with or without sodium thiosulfate. So if patient comes with cyanide poisoning, if somebody comes with cyanide poisoning, first you need to do decontamination. If there is dermal exposure, removal of the clothing, skin decontamination, ingestion. If he is ingesting some cyanide, activated charcoal, then all exposures, if all exposure, you should give antidote like hydroxycobalamin is preferred. It's a vitamin B12, hydroxycobalamin, sodium thiosulfate as an alternative therapy. Antidote actually not available. Nitrate to induce, you can give nitrates to induce methemoglobinemia. And respiratory support, no mouth to mouth resuscitation, and supplemental oxygen and airway protection, intubation should be done. And cardiovascular support should IV fluid for hypotension. So if somebody comes with cyanide poisoning, immediate care, remove the patient from the source, then discard his clothing, secure his airway with intubation. High flow oxygen, mouth to mouth resuscitation is contraindicated. And manage the hemodynamic stability by giving fluid and vasopressor, and administer benzos and charcoal for oral ingestion. An antidote, hydroxycobalamin, can be given. It's a preferred treatment. It binds with intracellular cyanides and form cyanocobalamin, which is renally excreted. And sodium thiosulfate, these one sodium thiosulfate, it actually availability of a the enzyme the enzyme that transfers sulfur to cyanide to form thiocyanate. It increases the availability of the sulfur for rodents. The enzyme actually transfer the sulfur to cyanide to form thiocyanate, a non-toxic. Thiocyanate is a non-toxic. So sodium thiosulfate function is to form thiocyanate, a non-toxic metabolite which is excreted through the kidney. So hydroxycobalamin, it is also excreted through the kidney. And the sodium thiosulfate, it is also excreted through the kidney, and you can do induce methemoglobinemia. Methemoglobin, like sodium nitrate induced mild methemoglobinemia, like ferrous moiety in the hemoglobin actually oxidized to ferric. Ferrous is oxidized to ferric, and methemoglobin binds to cyanide with high affinity, freeing the cytochrome oxidase and limiting the toxic effect. Okay, So risk factor for cyanide toxicity due to nitroprusside. Risk factor for cyanide toxicity due to nitroprusside include prolonged infusion more than 24 hours, prolonged infusion more than 24 hours, I have already told you, and high rate if it is more than 5 to 10 microgram per kg per minute, as well as CKD to prevent radio cardiorespiratory arrest and permanent neurological disability. Victims of smoking inhalation should be treated empirically. Victims of smoke inhalation treated empirically with for cyanide poisoning. Now, the very high yield topic, carbon monoxide poisoning. In carbon monoxide carbon monoxide poisoning, if we look at the carbon monoxide poisoning, again smoke inhalation, carbon monoxide poisoning, it is also a potentially lethal condition by inhaling the carbon monoxide gas. By inhaling the carbon monoxide gas, carbon monoxide binds to hemoglobin with greater affinity and displacing oxygen to create carboxy hemoglobin. This limits oxygen carrying capacity of blood and decrease the release of oxygen to tissue. So it forms carboxy hemoglobin and thus decrease the release of oxygen into the tissue. This carbon monoxide also directly impairs oxygen utilization by the mitochondria. Okay, if we look at the risk factor, smoke inhalation is the number one. Defective heating system, very high yield. You need to remember, defective or malfunctioning, improperly installed heating appliance like furnace and poorly vented fuel burning device like charcoal grills or kerosene heaters and motor vehicle exhaust in a closed place like garage. So garage, smoke inhalation, defective heating system, think about carbon monoxide poisoning. But smoking can happen, both carbon monoxide poisoning can happen in cyanide poisoning. Okay, manifestation, what happens in carbon monoxide poisoning? The manifestation mild to moderate headache, confusion, malaise, dizziness, nausea, and severe seizures, myocardial ischemia, and arrhythmia can happen. Cyanide toxicity actually impaired oxygen delivery because, carbon monoxide toxicity actually causes carbon monoxide actually this carbon monoxide binds with oxygen this carbon monoxide binds with hemoglobin with an affinity 200 250 times that of the oxygen. So carbon monoxide binds with hemoglobin very firmly, more than 250 times that of the oxygen, thereby reducing the number of the heme binding site available to bind with the oxygen and causing a large reduction in the oxygen carrying capacity. It also impairs oxygen utilization. And the symptoms I have already told you, and the severe symptoms like cerebral hypoxia can happen, mitochondrial ischemia, mitochondrial injury can happen, like carbon monoxide induced alveolar damage can happen, and it can cause anion gap metabolic acidosis. If you want to diagnose for physical examination, if you do some physical examination like pulse oximeter remains normal, but there is appearance of cherry red skin and mucous membrane. Cherry red skin and mucous membrane is rare, but an unreliable diagnostic sign. Diagnosis like in lab, in here there is increase in ABG, there is increased carboxyhemoglobin level, and in ECG with or without cardiac enzyme cardiac enzyme may be elevated due to myocardial ischemia or injury. ABG may show high anandamide metabolic acidosis, and lactic acid may be high due to peripheral tissue hypoxia, increased lactate production, and complete blood count, complete metabolic panel to look for ischemic injury to the kidneys and the liver. And the most important part, CT or MRI of the brain. CT or MRI of the brain is useful. In here, there is bilateral symmetric hyperintensity. There is bilateral symmetric MRI is sensitive actually, and these shows and particularly detecting abnormality in the globus pallidus. So bilateral symmetric hyperintensity, cytotoxic edema, bilateral symmetric hyperintensity in the globus pallidus, bilateral symmetric hyperintensity in the globus pallidus or basal ganglia structure are highly sensitive for hypoxic conditions. What diagnosis is measuring carboxyhemoglobin level more than 3% in non-smoker and more than 10% in case of smoker. So 3 for non-smoker, 10 in for smoker. What are the differentials? Differential can happen like influenza, like migraine, like meningitis, and DKA. One of the differential. Okay, and the management. Okay, okay. Standard pulse oximetry is unreliable and may appear normal because it cannot differentiate the carboxyhemoglobin from oxyhemoglobin. It cannot differentiate carboxyhemoglobin from oxyhemoglobin. What is the most likely diagnosis? A patient with headache for 2 months with a recent decline in the performance in the school. He lives in the basement of the house and lab his hemoglobin is very high. Cerebral hypoxia due to secondary to carbon monoxide poisoning. So he's living in the basement of the house where there is poor oxygen. So cerebral hypoxia secondary to carbon monoxide poisoning, hemoglobin is higher. Carbon monoxide binds with the hemoglobin 250 times or 240 times stronger than oxygen and prevents normal oxygen delivery to the cell, leading to chronic hypoxic state, stimulating EPO production. So carbon monoxide actually binds 240 250 times stronger than the oxygen and prevents oxygen delivery to the cell and leading the chronic hypoxic state and stimulating EPO production. Carbon monoxide poisoning induced myocardial infarction. It can cause chest pain, ECG changes, elevated troponin, bilateral radiographic infiltrate, no acute coronary occlusion. No acute coronary occlusion. Okay, no acute coronary occlusion. Okay, finally, one important thing like inhalation injury. The pathophysiology is upper airway thermal injury and lower airway chemical. Upper airway thermal injury with or without lower airway chemical. Concomitant dioxide, uh, carbon monoxide and cyanide poisoning is common. In inhalation injury, concomitant carbon monoxide and cyanide poisoning is common. Concerning feature smoke exposure in enclosed space, physical like singed in inhalation, like singed hair, facial burn. The, this word is very high. Singed hair, facial burns, and carbonaceous sputum, wheezing. Strong indicators of the airway injury. Strong indicators of the airway injury. Oropharyngeal blistering or edema, retraction, respiratory distress. Management is 100% oxygen to displaced carbon monoxide, stable patient with concerning feature but no strong indicator, bedside fiber optic laryngoscopy, very, very high health. Like in inhalation injury, stable patient with concerning feature but no strong indication, bedside fiber optic laryngoscopy should, unstable patient, endotracheal intubation should be done. So in inhalation injury, unstable endotracheal, stable fiber optic laryngoscopy. Okay, so that is all about cyanide poison. So that is all about cyanide poisoning, carbon monoxide poisoning, and inhalation injury. Hope you enjoyed. In the second part of the video, I will discuss about the questions of cyanide or carbon monoxide poisoning or inhalation injury. Hope you enjoy.